Good afternoon. I'd like to thank the organizers for accepting this abstract for oral presentation. Title is Outcomes Associated with Belimumab in Patients with Systemic Lupus in Clinical Practice Settings in the United States. These are the relevant disclosures for this presentation. So a short background, as many of you are aware, Belimumab is a human immunoglobulin monoclonal antibody and inhibits the biologic activity of soluble B lymphocyte stimulator, or BLyS. It was evaluated in 2 large phase 3 randomized controlled clinical trials, and in March of 2011 was brought to market in the United States for the treatment of adult patients with active autoantibody positive lupus receiving standard of care therapy. The OBSERVE initiative is a multi-center retrospective medical chart review study, and we will be presenting the outcomes for the first phase today. Methodology: rheumatologists in clinical practice settings and non-academic centers in the United States were recruited. They had to have had at least 5 patients, and managing at least 10 patients, for non-academic centers have had at least 5 patients whom were prescribed Belimumab, and with at least 1 or more patients whom had received at least 6 months of therapy, which approximates to 8 infusions. The patients were adult SLE patients prescribed Belimumab as a part of usual care, and they were not enrolled in other lupus trials. Data collection was conducted using de-identified data. They were allowed to contribute anywhere between 5 and 25 eligible patients, and we used both patient case report forms describing a variety of clinical outcomes and physician judgment scales, which I'll talk more about in a second, as well as physician practice profile form. So this is the design of our study. Phase 1 represents a previous 6-month history retrospective chart review followed by a 6-month follow-up. Phase 2, which will be ongoing, is a prospective looking at the subsequent 2 years after Belimumab initiation. The index date in this case was the date that Belimumab was started. The key endpoints: overall clinical response to Belimumab at 6 months, a change in individual clinical manifestations at 6 months, and we looked at steroids as well. Analysis was based on presumptive data using descriptive statistical methods according to a pre-specified analysis plan. So these are our baseline patient characteristics. The mean age was a little over 40 years, was predominantly female. You can see that there is a broad distribution in the ethnicity and racial subgroups of the patients enrolled, despite a despite a cautionary note about the use in African Americans. Approximately 24% of the patients that were evaluated in this trial were indeed African Americans. Over half were diagnosed with lupus within the past 5 years, and 97% of the patients were deemed to have severe to moderate disease. Concomitant medications included 78% of the patients on steroids and over 60% on concomitant immunosuppressive drugs. Approximately half of the patients were deemed to be positive double-stranded DNA at index, as well as hypocomplementemic. The mean prednisone dose for the patients on prednisone was approximately 20 milligrams a day, and 70% or a little less were on what we would consider supraphysiologic doses of 7.5 milligrams a day or more. About 25% of the treating physicians utilized the SLE in their clinical practice, and the mean SLE of those patients was 12.4. So this is our data. Let me tell you a little bit why we chose the endpoint that we did of a physician global assessment of improvement. As I said a few minutes ago, only about 25% of the physicians were utilizing the SLE as a primary outcome tool, and so we felt there was not a widely accepted, commonly agreed upon endpoint in this cohort of non-academic rheumatologists. And so we asked them to basically give us a physician global assessment of how they felt their patients were doing relative to the index period. We asked them to then divide it into a percentile. This is 20, 50, 80% improvement to reflect already an accepted nomenclature for what we see in rheumatoid arthritis studies. And so what we can see is that the majority of patients were felt to have improved by some degree. And if we choose 50% as the marker for which we look at overall improvement as a meaningful clinical endpoint, about 50% of the overall cohort was felt to have improved by at least 50% at that 6-month period. I called attention to the enrollment of African Americans, and we presented this in Washington, D.C. at the ACR last year. Again, there was no difference in any of the racial groups, including African Americans, in their perceived response to this medication. When we broke this down by clinical manifestation, both by organ domain as well as specific clinical entities, we can see that there was across-the-board equivalent improvement in multiple domains. The top 5 listed here include musculoskeletal, cutaneous, immunologic, constitutional, and hematologic. And the individual manifestations mimic this as well, with almost 40 to 50% of the patients improving by at least 50% or more in a variety of objective and subjective markers, including improvement in hypocomplementemia and double-stranded DNA antibody titers. We also looked at steroid dose. We see that the mean reduction, steroid dose in the middle, mean reduction of 11.5 milligrams. Approximately 77% of patients were able to reduce their steroid dose by some degree. Almost 10% were able to decrease their steroids to 0. And for those patients whom had a SLEDAI measured at baseline, the mean SLEDAI reduction was 6.5. We also looked at health resource utilization from the pre-index to the post-index period, the number of hospitalizations, as well as ER visits, unscheduled visits to treating physician, and visits to other specialty physicians all saw statistically significant decreases. So, given that this is a retrospective medical chart review, there is obviously a number of limitations we must take into consideration. Pre- and post-analysis allows for a description of what was observed only among patients exposed to Belimumab, and causal inference of any of the effect of Belimumab cannot be made as analysis did not have a control arm. The results are not generalizable to patients who had received less than 6 months of therapy. Treatment patterns, clinical outcomes, and resource use data only represent the practices of the physicians participating in the study, and they may differ from non-participating physicians, and we did not assess safety. So in conclusion, amongst patients with at least 6 months of exposure to Belimumab, we observed overall improvements in clinical manifestations using a physician global assessment-driven scale, as reported by clinicians for the majority of the patients treated with Belimumab. 1% of patients or less had worsening or no change in their clinical manifestations, and steroid doses were reduced in the majority of study patients who were taking steroid doses at baseline. Thank you very much.
Probably we have time for one short question.
Thank you for a very interesting presentation. You mentioned the outcomes up to 6 months. I suppose the most interesting thing is, what did physicians decide to do after that? So did you ask, are you still following them up? And secondly, did you ask physicians whether they intended to keep the patient on therapy? And
yeah, so this is the purpose of the phase 2 aspect of this program. So we're going to continue to follow the same physicians following the same patients longitudinally for the next 24 months. And from that, we'll take a look as to not only whom are still being continued on this medication. If they're withdrawn, we'll find out if there are other reasons why they're being withdrawn. And we'll take, again, continued look at perceived efficacy, medication uses, laboratory data, etc. Thank you very much.